a survey meter. A portable survey meter would be sufficient to detect surface contamination. And don't forget that because the lutetium-177 has a gamma emitter, and that helps us to help it to be detected and monitored as well. And of course, screening of the environment, contamination, toilet, etc., can be done with that as well. And washing facilities are required for emergency as well. And we always have a standby radioactive spill kit. And we also have a list of things that are kept inside, and we have to check it on an annual basis. Well, a job for one of our physicists as well, to ensure that it is always stocked and kept ready all the time to be used anytime. So this helps us to speed up the process of looking after contamination. And as you can see, most of them are regular items that you can get. Perhaps the only thing that is unique would be to the maybe the radioactive label. That may be the only thing that is different. Otherwise, they are the regular stuff that you can get from the pharmacy or for your material management department. Staff exposure, well, TLD OSLs are generally worn on the waist level, and of course, for the staff that are handling the radionuclides, we also give them the extremity dosimeters as well to help to determine how much exposure their fingers receive, and that is also an issue because we need to make sure that they are within the 500 millisieverts of radiation per year. And we have sufficient radiation survey meters, etc. Some of them are installed on the wall so that they are hands-free operation, so we can check our hands. And if the hands are free, then we can lift off this survey meter, the detector part of the survey meter, and use it to check whether our clothing or our feet are clean as well. Now, the release of lutetium peptide patients, there's no consensus around the world. In fact, some places are actually treating it as an outpatient treatment. They're starting to do that as well, but some places are still treating that as at least for the first 24 hours to be an inpatient before they discharge. So whatever it is, it's a very short discharge. They don't keep these patients in the hospital for such as iodine 131 for thyroid cancer treatment, not as long as that, but even then, there is when we're talking about the release, a decision is made because it's based on the regulatory compliance in your country, and also is based on the residual activity inside the patient or the dose rate at a specific distance of generally 1 meter away. And of course, it also depends on the medical condition of the patient, whether the patient is stable enough, fit enough to be discharged for home. ICRP, the cornerstone of ICRP is basically dose limit to the public and also dose constraint to the family and the carers. And based on Makoto, what he did discover in 2018 is that the calculation of the cumulative dose to the third party exposed at a certain point after treatment of 7,400 megabecks of this over 4 rounds of treatment. And immediately after the patient has been infused with it, the caregiver and general public, they get about 2 millisieverts or 1 millisievert. And at 24 hours, they get about this much. And as you would realize, as most of the peptide is leaving through the urinary system, the patient will be less and less radioactive. This is what Kevin realized back in 2019. He published a series of admissions for lutetium DOTA patients, and generally they were given about 7 to 8 GBQs total infusion. And at the end of the infusion, this is the kind of dose rate in micrograys per hour, and that goes down to about 60% down at the point of release, and 48 hours later, they're not detectable at all, the radiation exposures. With that, talk about the discharge advisory for 1 week. We tell our patients, we give them verbal as well as written instructions as to ask them to flush the toilet twice after use, and males to sit down while they are urinating, and also considerably contaminated clothing should be washed separately from the rest of the family, and avoid close and prolonged contact with adults for 3 days, avoid close and prolonged contact with children under 10 years, and pregnant women for 1 to 3 weeks. And of course, the regular information we tell them about pregnancy and avoiding impregnation as well for our patients. And the advisory basically also talks about how long they have to stay indoors before they can travel outside of their home, especially when they want to take a flight. And that's something that we have to grapple with. We have to interview these patients prior to the treatment, whether if they are foreigners, if they have to fly away, how many days they have to stay indoors before they can take a plane out. I wish to summarize by saying that radionuclide therapy is an effective treatment modality for some cancers, and lutetium peptide therapy is an effective method for treating unresectable metastatic neuroendocrine tumors with significant disease response and control rate. And several hospital radiopharmacies cater to the needs of large number of our patients of progressive metastatic and advanced NETs. Justification of practice is the therapeutic benefits of the exposure are weighed against the radiation detriment. Of course, this justification has to be done prior to any form of treatment for that matter. And the optimization of protection and safety for our staff, as well as the next of kin of these patients, has to be looked after. And generally, the medical physicists play a crucial role in ensuring that the staff as well as the environment are safe post radionuclide therapy. I wish to thank you for the attention, and of course, I wish to urge all of you to come next month. Our borders are open to the IUPESM World Congress of 2022 in Singapore, physical conference as well, from the 12th to the 17th of June, less than a month away. So please book your tickets and hope I can see you here in Singapore. Thank you.
Thank you so much, Mr. Soma, for very clear explanation as usual. We received some questions and also comments from the participants. Wow, they all thank you for the excellent presentation. There's one question for Sachin, but Yang Sun already answered. So he asked, how many cycles of PRRT are you administered on average? Okay. So Yang Sun explained it's about 4 grams per patient.
Yeah. Absolutely right. Yeah, that's right. Yeah. Thanks.
Then Sachin also asked about the long-term response. You have any ideas?
The long-term response of peptide therapy, is it?
Yes.
Okay. It's a good question. Clinically, I can't answer that because I need to check with my doctors. But I do believe one of the premier sites that actually did this peptide therapy, in fact, the place that we went to look and study how it is done before we started at our own hospital was in Bad Berka under Professor Richard Baum. And he had patients who were disease-free survival after 15 years as well. Wow. So it's amazing, this treatment. Of course, we also need to know that no two patients are the same. Of course, sometimes the what do you call it, the relapse is uncontrollable, and it also depends on what stage the patient is when they come to us for this treatment. If it is the last stage, then the stage 3, stage 4, the chance of survival it goes down, of course. Yeah. Like in any other cancer treatment as well.
Yeah, thank you very much. Another question from Putipon.
Yeah, Putipon, yes. Yeah. Hi, Putipon. Nice to hear from you. He has a question about urine waste.
Urine
Seems
waste.
to be collected in the urine bag via catheter. Is this applied for all patients? What will happen if you need to keep it frozen until decay? Many thanks, Alicia. Okay, thanks, Putipan, for this very important question. We only catheterize some of our peptide therapy patients who cannot hold their urine, not forgetting that they are infused with the amino acids, and that will make them want to go to the toilet quite quickly. So if patients cannot hold their urine, we catheterize this patient because we want to know, especially for dosimetry sake, all the A0 or the initial activity that is infused inside our patient. So for that, we actually image the patient together with the catheter. So that's the reason why we catheterize these patients. And of course, we do not keep it in the refrigerator, but we rather discharge it into control discharge into the toilets which have got a septic tank or a delay tank, so that they go together with the other radioactive urine from other patients as well. Thank you for the question.
Yeah, thank you very much. For Melvin.
Okay, that would be something that all our doctors want. They want to start treating outpatient basis, and that is something that private centers are also looking forward to. And I think it will start soon. It's the fact that, as I mentioned in my talk, we need to look after the small proportion of patients who crash, who BP goes crashing because of the high concentration of amino acid infusion. So because of that, we are keeping these patients. So if there's sufficient data to suggest that the patient will be safe from the amino acid treatment prior to the radionuclide lutetium-177 peptide treatment, then perhaps there will be a very good case for outpatient treatment. Once again, it's regulators as well. So one needs to look after your own country, your own state, whether the regulator would allow for such a thing to happen as well.
Yeah, thank you. So, Mr. Soma, for the outpatient, inpatients, like for the inpatient, is it the concern, is it mainly on the radiation protection part, or is the clinical part?
The clinical, Chai-Hong. Yes, it is a clinical aspect of it because of the neuroendocrine, because of the blood pressure can crash. That's the only reason. Like, for example, the PSMA treatment in Singapore, we do it as outpatient, purely outpatient, you know. And it's using the same lutetium-177 radionuclide.
Yeah. Yeah, I also say in the Europe, they are mostly done on outpatient basis. Yeah. Okay, thank you. From Sachin again, sorry, I missed it. How do you titrate the dose in patients with renal conditions?
How do you titrate the dose? That's a good, that's the, well, I mean, for sure, they give them a lower radiation dose if they have a renal condition, but I am not sure how scientifically they can titrate. What is the ratio? That I'm not certain. And I think it's a more clinical question. I'm so sorry about that, but hopefully we can get back to you on this. If you can send us an email, I can ask my medical colleagues.
Okay, and for Siraport, thank you for interesting talk. What are the factors that determine the type of radiopharmaceutical between iodine-131, MIBG, and lutetium dotatate?
Okay, this is also a little bit of clinical question actually, but iodine-131 MIBG says specifically for neuroblastoma, and it works very well for neuroblastomas. But in the case of NETs, lutetium-177 is generally what we use these days for the treatment. It's because of its efficacy, because of its ability to be discharged within 24 hours post-treatment. It is much more popular than the I-131 MIBG. And I'm not sure about the cost implications of it, but we do like about 70 patients a year, whereas iodine-131 MIBG, we do only like maybe maximum 1 to 2 a year. So in that sense, I would say that it is clinically more better results with lutetium-177 based peptide treatment.
Yeah, thank you very much, Mr. Soma. We do have other questions. We might come back if we have questions later. Yeah, thanks again, Mr. Soma.
Sure, thanks.
Okay, let's move on to the next talk. So the next talk will be by Dr. Kitty Watt on prostate cancer using lutetium-177 PSMA. So, Dr. Kitty Watt also don't need my introduction. He is popular in the region. He is an assistant professor and a medical physicist in nuclear medicine, currently in Chulalongkorn University. He did the PhD from Chulalongkorn and followed by postdoc fellowship in Johns Hopkins University in the USA. Dr. Kitty Watt, are you ready?
Yes, sure.
Great.
Thank you so much for your nice introduction about me. Yeah. Let me share my screen. All right, can you see my screen?
Yes, we can see your screen.
Okay, all right. So thank you so much everyone for participating this talk. So my talk will be about the radioimmunotherapy for prostate cancer that emphasize for the lutetium-177 PSMA. For my introduction regarding the lutetium-177 PSMA. So right now, prostate cancer is one of the most common cancer among male population in worldwide, according to the American Institution for the Cancer Research report. And it ranked the first most common cancer in the US, around 100,000 and around 160,000 cases, accounting for around 90% of the patient for all new cases. This is the report from the American Cancer Society in 2018. In Thailand, according to the report of the National Cancer Institute, around in 2017, the number of the new prostate cancer patients ranked the fourth out of the new cancer patients. And this is another report from the Global Cancer Incident in the main from the World Cancer Research Fund and American Institute for the Cancer Research. About almost 50% is the prostate cancer, more than 1 million of the people for the new case diagnosed in 2018, and most of them are the metastasis castration-resistant prostate cancer. In order to, so for the approach, the current prostate cancer therapy approach for the local treatment for the early stage, the surgery and radiation therapy are used to eradicate the cancer from a specific area of the body. This is for the local treatment for the early stage. And then when the cancer spread or metastasis to the another part of the body of the patient, so we, the doctor probably use the chemotherapy to kill rapidly proliferating cells and use the hormone therapy to inhibit the signaling pathway that tumor cells are addicted to, and use the immunotherapy to overcome the immune tolerance to cancer. But right now we have the radiopharmaceutical therapy that used to kill the target cell by localized radiation delivery. So this is the modern nuclear medicine that we have, the theranostic, and we are going to the precision medicine as the Dr. Chai Hong mentioned for her talk. As we know about for the radiopharmaceutical therapy or RPT, difference from the external beam therapy that require the knowledge of the tumor location. In case of the RPT, also require the knowledge of the tumor biology. And I think all of you know well about this concept. The agent that from radiopharmaceutical distribute throughout the body of the patient and bind to the target cell and then clear from the non-target cell, and prolong exposure to target cell and give large radiation dose to target cell than the normal cell. So that's why the complication of the radiopharmaceutical therapy compared to the external beam therapy is quite a little bit lower. So this is the example of the publication per year related to the RPT. So this is the publication regarding for the beta emitter. So you can see that previously most of the research emphasize for the iodine 131, as Dr. Krishnat mentioned. And then the number of the publication for the yttrium-90 and lutetium-177 and samarium is increasing, as you can see from this slide. So this is the report from the Nature Review delivery in 2020. And this is for the alpha emitter RPG. So you can see that the number of the publication has increasing also. And the actinium-225 is very popular right now. And if we classify according to the type of the cancer, so you can see here, so the majority is still for the thyroid and hematological malignancy. But right now, the neuroendocrine and prostate cancer, and for the breast and also for the hepatic cancer, I guess this use the yttrium-90 is increasing as well. This is from the same report. Well, I would like to share all of you about the experience of the theranostic at King Chulalongkorn Memorial Hospital in Thailand. So most of our case is the prostate cancer. So we diagnose the patient with the gallium-68 PSMA. And right now in some hospital in Thailand, we start using the fluorine 18 PSMA for the diagnostic for the PET imaging. And then not all of them pass the criteria to treat with the lutetium-177 PSMA. So only about 50% or 60% pass the criteria. So this is the number of the report in our hospital from 2018 into 2019, and we had the fire accident, and then we start the service recently. And for the prostate cancer treatment that use the lutetium-177 PSMA, this is a very promising radiopharmaceutical for the prostate cancer treatment. The PSMA stands for the prostate-specific membrane antigen. So in order to treat the patient, we need to do the diagnostic first. So we know what site will be treated. This is for the diagnostic scan using the gallium 68 PSMA or probably fluorine 18 PSMA as well. And I think our speaker already mentioned the property of the lutetium-177 PSMA. I will skip this. And then after the patient passed criteria for the diagnostic, and then we send them for the therapy to confirm that the site is treated correctly. We have to scan the patient for the post-therapy scan as well. This is called the theranostic, as Dr. Chai Hong mentioned. Well, this is the example of the gallium-68 PSMA 11, sorry, for the PET-CT imaging. So the administered activity about 5 millicurie approximately, and we do the imaging at 1 hour after injection. And then the criteria for the patient who will pass the criteria for the treatment is the uptake at the tumor or the in the tumor should be greater than or equal to that bar in the liver. And then after that, we do the post scan we do the scan for the post treatment. This is the state of the art treatment in modern nuclear medicine. As I mentioned, we know what site will be treated by the diagnostic scan, and then confirm that this is treated correctly by post-therapy scan to demonstrating the achievable tumor doses. And well, we have the lutetium-177 that is very popular, and so this one for the actinium-225. And in Thailand right now, we start using the actinium-225 as well. So we see what we treat, right? And we treat what we see. This is the concept of the theranostic. And this is the first patient of the lutetium-177 PSMA that treat in Thailand at King Chulalongkorn Memorial Hospital. This is our head division, and he already retired from our department. And then we do the imaging for the sequential imaging for dosimetry calculation. This is our team. And then we calculate the internal dose according to the MERT method that our speaker already mentioned about that. This is the simplify of the equation. I just would like to explain to all of you. So the absorbed dose in the target organ is the this is the combination between the summation of the time integrated activity in the source organ multiplied by the S value. So you need to define which organ is the source organ and which define is the source organ. So we calculate the dose in the target organ. So this is the Merck equation according to the Merck pamphlet number 21 that published in JNM in 2009. This is the latest version. And in order to calculate the dose, we have to acquire, we have to scan the patient several times. So at least 3 times is recommended. And then we integrate area and we measure the activity in each of the time point and integrate area under the curve to obtain the time integrated activity, as I show in these slides. And then we can calculate the residence time. This is the former name, and the current name is the time integrated activity coefficients, or TIAC. So that's why the beta and the alpha particle is very popular for the radiopharmaceutical therapy right now. So according to the absorb fraction, so you can see here for the electron or the alpha, the absorb fraction from the source to the target organ is the 0. So most of them deposit in the source organ. So when we calculate the absorb dose in target organ according to the Merck method, the Merck defined that the absorb fraction from the source to the source organ, so it means this is the self dose equal almost 1 or 100%. So this is the example of the dosimetry calculation and dosimetry approach at our hospital. So we do the planar imaging, and actually we do the SPECT imaging as well by using the medium energy collimator. And then so the lutetium-177 can do the imaging by acquire the gamma ray with the energy of 113 keV and 208 keV. And then the table speed for our protocol is about 10 centimeters per minute, and we scan the patient 5 times. Actually, this is too many. But for the first cycle of the treatment, we try to do the full dosimetry in all of the patients. And then for the next cycle, we can acquire like only 3 time points. And anyway, we have to concern about the external and internal exposure and the contamination, as Soma mentioned, and nephrotoxicity evaluation should be done. This is the example of the biokinetic data of the lutetium-177 PSMA from our patient. So, and then we can use this biokinetic data to determine the absorbed dose in the target organ. So this is the example of the biokinetics data in source organs such as in the kidney, liver, spleen, and in bladder. And also this is for the whole body. And well, the dose limit for the in order to avoid the toxicity to the critical organ. So this is the example of the calculate absorbed dose to the kidney. So the dose limit is about 23 gray. So as I mentioned, most of the absorbed fraction using of the lutetium-177 is the self dose. So that's why the S value we calculate the most of them of the absorbed dose come from the self dose. So in the kidney, so we calculate the S value from kidney. We use the S value from kidney to the kidney, and then you can take a look at S value from the published data. As I mentioned, it would be great to concern about the cumulative dose for the organ at risk when we use the radionuclide therapy for the patient, and also for the lutetium-177 PSMA. So in our center, we calculate the dose for the bone marrow, kidney, lacrimal gland, liver, and salivary gland. So this is the dose constraint for absorbed dose in those organs. This is the publication from our center regarding the patient dosimetry of lutetium-177 PSMA INT in metastasis prostate cancer treatment patient. This is like the very first experience in Thailand that published in Annals Nuclear Medicine last year. So for those who interested, I can share our paper to you. Well, so this is the result from that study. So this is the absorbed dose in the kidney. This is one of the critical organ that we most concerned when we use the lutetium-177 PSMA and also for the dotatate as well. So this is the result from our study is quite a bit higher compared to the another study that published in the JNM and EJNA as well. But the result is still comparable. So according to the absorbed dose that you obtain from the dosimetry calculation, so you can predict the cumulative absorbed dose in the critical organ. And then, for example, like if you, for the average of the treatment cycle, about 4 cycles, as Yong-sun and Soma mentioned, so you can determine, okay, in the overall how much of the accumulated activity of the absorbed dose in that critical organ in order to avoid the toxicity to the critical organ. And this is another result for the bone marrow. So our study, the dosimetry, according to our study, is comparable to the published data, about 0.02 gray per gigabecquerel. This is for the administer about 7.4 gigabecquerel of lutetium-177 PSMA. And this is the absorbed dose in the lacrimal gland. So we use the spherical model to calculate the dose for the lacrimal gland. This is the spherical model can use for the lacrimal gland or the small organ, and also for the lesion dosimetry as well. So you can see here, this is the result from our study is quite comparable to the published data as well. And this is the overall of the absorbed dose in organ at risk, in several organ at risk. So, sorry. Okay, right. In the lacrimal gland, kidney, bladder, parotid gland, spleen, liver, submandibular gland, and the bone marrow. And so we see, like, and we also compare the dosimetry in the same patient between the first and the second and the third cycle in the bone marrow. So the absorbed dose in bone marrow, this is was correlated to the level of the skeletal metastasis. So it means that the bone marrow absorbed dose should be in order to avoid the bone marrow suppression. And well, I would like to share this this thing to all of you. So right now, as I mentioned, so in order to calculate the dosimetry for the theranostic, this is would recommend for those for in the center that never done about the dosimetry before. Even though you can take a look the dosimetry from the published data, but it would be great if you can do the dosimetry by yourself in your center and use it as the baseline or the database for your patients. But as our speaker mentioned, this is quite a burden, a lot of the burden for the patient to acquire several times and to calculate the dosimetry. So right now, several studies, several researchers try to establish the dosimetry based on the single time point. So this is the example from the white paper from the MIM software that use the data from they refer the study from the Hachi that et al. That published in the JNM in 2018 about the approach. So this is the example for the lutetium dotatate, even though not the PSMA for the prostate cancer, but I guess this approach could be applied to the another kind of the radiopharmaceutical. And yeah, they use like the prior information approach for the dosimetry. As you can see in this slide, and then they like compare the result of the dosimetry between the full the multi-time point absorbed dose and with the single time point absorbed dose here. They found a very good correlation between the multiple time point acquisition and the single time point acquisition. Anyway, according to their study, as I mentioned, for the first cycle of the dosimetry should be acquired for the multiple time, but for the later time or for the another cycle. So it would be great, if possible, to use the single time point to calculate the dose by using the prior information approach. And according to the recommendation from the several study, so most of them suggest that if we need to calculate the dosimetry from the lutetium-177, acquire the data at the 72 hours after injection, or during the time at the 72 to 76 hours after injection. This time point would give you more accurate of the dosimetry based on the single time point acquisition. And another thing I would like to share with you, right now at our center, we try to use the commercial software to calculate the dose in the patient who treated with the lutetium-177. So this is the example. So we try to use the dose volume histogram, but right now the dose volume histogram mostly used in the radiotherapy, but in nuclear medicine field is quite new. It's still like on the learning curve. So there is no standardized to use the DVH in nuclear medicine right now. So we need to collect more data about that. And what you can see here, so according to the commercial software, we can obtain the lesion dosimetry here, and we can obtain like the isodose, and we can obtain like the maximum dose, maximum absorbed dose in the tumor, and this is the isodose in the tumor, as you can see here. So because in the real thing, the absorbed dose in the tumor or even in the organ is not the homogeneous. So that's why this is probably very useful for the treatment planning using of the radiopharmaceutical in the future trend. And this is another example. We use this software to calculate the absorbed dose in the normal organ here in the kidney. And this is the result. So we can obtain the result for the organ at risk and also in the tumor. And then we can determine the dose should we give to the patient for the next cycle. And this is another example for the treatment outcome of the lutetium-177 PSMA for our patient at King Chulalongkorn Memorial Hospital. This is before the treatment. So you can see the metastasis of the cancer to the another part of the patients. And then after treat with the lutetium-177 PSMA 2 months later, so you can see this is a very good outcome of the treatment. So that's why lutetium-177 PSMA is very popular right now. Okay, and this is another suggestion from the researcher from the Germany. By adding the interim scan during the prostate cancer therapy can help to guide the treatment direction. And this is the example after the 2 cycle treatment of lutetium-177 PSMA. So you can see that the imaging can help to predictive value for the patient survival. This is, I always show this picture for the participants. So this is like the image of the year in 2018 from the ASNA meeting. So this is a very promise of the treatment using the lutetium-177 PSMA in different patients. This is the result from the study from the German group. So you can see here, this is the before the treatment and then after the treatment from 8 patients. And then right now we have the novel radio tracer called FAPI. This is stand for the fibroblast activation protein inhibitor. So do you believe this tracer can detect almost 78 cancer type And this is paving the way for the development of the new diagnostic. So this is the image of the year from the SNA meeting in 2019. So this is also this radio tracer can detect several of the cancer type, as you can see here. This is the study from the researcher from the Heidelberg in Germany. So that's all of my talk. And in summary, regarding my talk, diagnostic involved in radionuclide pair and intimately tied to radiopharmaceutical therapy, and this is the concept of the diagnostic and may be used for the dosimetry, and matching half-life with kinetic of radiopharmaceutical therapy is critical. Imaging will be different for the new therapeutic agent and try to expand scope of the radionuclide. And right now, alpha emitter is ascendant due to the high LVT particle and deliver directly to the cancer cells. All right, thank you so much for your attention. That's all of my talk.
Thank you so much, Dr. Kittiwat. Very, very nice presentations and sharing of your experiences. That's very nice.
Thank you.
Yep. There's one question, and I think your colleague already helped to answer it. It's from Zulaika. If you remember, Zulaika is from Malaysia.
Yes.
Yeah.
Okay. All right.
She's asking about the guidelines or the reference for your tolerance dose.
Oh, okay. All right. So, so the guideline for the tolerance dose. So right now, the ENM and SNMMI and also the IAEA, they publish the guideline for the tolerance dose for that. So I think I can provide it to you. I can share it to you about the tolerance dose of the critical organ.
Yeah, that's great.
And I would like to say that this is just recommendation. So difference in each of the patient. So this is just the guideline. It doesn't mean that if your patient, the kidney receive like 23K, will be the toxicity for the kidney. No, absolutely not. This is depend on the individual, but just for the guideline.
Yeah, thank you for that. Yeah, Onisha.
I think someone already mentioned. Right, for the birth pamphlet number, right, correctly.
Yeah, and I see in birth pamphlet number 26, and I wondered, it tells us that there are many different.
Yes, right. So, so you mean you see the difference number of the dose tolerance, right?
I think she's asking, is there big difference between the two documents? The one you mentioned is IAEA, is it?
Yeah. Okay. Well, so in general, a lot of the right. I would say that, yeah, in some publication they use like, I'm not sure, higher of the absorbed dose for the kidney, but so right now, for example, in our center and several center, they start from the 23 gray, and then in some publication, so you have to take a look if the difference of the number based on the absorbed dose or the BED. For the BED, the number is higher if you use the BED base. I'm not sure.
Thank you. Thank you so much.
I'm not sure I answer your question or not.
Yeah, I got it. I got the point. Thank you.
Yeah.
Dr. Kittiwat, may I add something? Because in my presentation, there is a study involving 707 patients that those two kidney will not reach 10 gray. So it will be really low. That's yes. Come from the maybe I will do later for presenting some evidence. Okay, thank you.
Yeah, yes, that's great.
Yes.
Yeah,
thank
so
you.
please stay on to Kak Noor's presentation later. And Dr. Kisana also helped to answer the tolerance dose. Most came from the EBRT, yeah, which is very true. Yeah. as we say, the nuclear medicine dosimetry is just like started, you know, the trend is just in the past, actually it's in the past 5 to 10 years. So it's still debating issue. Yeah.
Yes, right. So we need to, yes, right. So that's why you see a lot of the difference, the huge difference of the number for the tolerant dose in nuclear medicine, right? So that's why we need to collect more data about that.
Yeah, that's good. And Melvin also say, is there any similar method or application in radiation therapy, like treatment planning system that can be used in nuclear medicine? Yeah, I think, yeah, Kitty, what you can answer this.
Yes. According to, based on my experience, so right now I use the MIM software and also for the Hermes software. That is the very, I think this is a good software for the treatment planning. But for example, like the Olinda, this is the good for the dosimetry calculation, but they recommend that like this is not to use for the radiotherapy treatment planning. And also you have to take a look the recommendation for those of the software that you need to use it. They recommend it to use for the radionuclide therapy treatment or not. And right, so as Dr. Chai Hong mentioned, using the software for the treatment planning in nuclear medicine right now is quite very new. It's still like the learning curve. So we need to collect more data and more evidence for that.
But we will be there. I think 10 years from now, 20 years from now, you will see the same TPS system for nuclear medicine.
Even like, for example, like even because the MIM software can be used for the, I'm not sure for the radio external beam radiotherapy as well. I'm not sure about that. And you can see even the treatment planning provide you the dose volume histogram. But right now we don't know exactly how to use it. The percentage of the dose coverage, percent dose coverage should be take a look, should be pay attention. This is the
Thank you so much, Kitivat. Any other questions? Yeah, if not, shall we move on to the next talk?
Okay, thank you.
Thank you, Kitivat. Okay, our next talk is from, sorry. Okay, next talk is from Mr. Tae Yang-sun from the same hospital with Mr. Soma on the intraarterial radiation therapy for liver tumors using yttrium-90 microspheres. So let me briefly introduce Mr. Tae Yang-sun. He's a senior medical physicist from Singapore General Hospitals, and there are multiple appointments here. So maybe I let Mr. Tae to introduce yourself. Is that okay?
Sure.
Yeah. Thank you, Yang-sun. You can start anytime.
Okay. So good afternoon, good morning, and good evening, everyone. I'm a senior medical physicist from Singapore General Hospital, and today I would like to talk about the intraarterial radiation therapy for liver tumor with Y90 microsphere. So let's start the presentation. So currently on the market, they have two types of microsphere. The first one is the resin microsphere from Surstech, and the second one is the glass microsphere from Pearsphere. They are characteristic about the same, just that the concentration of the activity is different, and the size for the two particles are actually quite similar. They have comparable diameter, 20 to 60 micrometer. So due to their size, they can be tracked by the small capillary vessel. The half-life of Y90 is 64.1 hours, considered as a pure beta emitter. So that's why it's make direct imaging on the gamma camera become very difficult, because they don't have any appreciable gamma emission from the Y90. The maximum energy for the beta particle is about 2.28 mega electron volt, and the average energy is about 0.9. So to convert into the travel distance in human tissue is roughly about 11 millimeter for the maximum, and average will be 2.4 millimeter. It will be used as a targeted radiation therapy. And for this purpose, right, the Y90 microsphere will deliver most of its energy in 2 weeks' time. So after 2 weeks, the patient probably will be free of radiation. The 1ID embolization, the intended end is actually become a selective internal brachytherapy. The clinical effect actually is a relationship between the administrator activity and the tissue dose, and it shows strong correlation between the radiation dose absorbed by the tumor and the improvement in progression-free and overall survival. So on the graph, actually, you can see for patients who receive more than 120 gray for their tumor absorbed dose, the median survival is significantly longer compared with those receive less than 120 gray. The response from 190 embolization is ranging from 78% to 89%, fewer hospitalization and average fat compared with TAX. The tumor complete response and the partial response is higher with the SUSPEAR, higher response and down staging rate as well. The median time to progression also is longer. However, the median survival is unchanged compared with the TAX. It's about 17.2 months for the intermediate state and about 12 months for the advanced state. Due to the strong correlation between the tumor absorbed dose and the overall survival, 190 dosimetry will be very crucial. And we have to measure the absorbed dose, which is the biological effect of radiation of the target volume or target lesion. And this parameter will be depend on the following character, like the activity we deliver into the target, the volume of the target as well, and how is the distribution, whether it's homogeneous or heterogeneous. And for administration model currently used in clinical practice include the body surface area, skin, as well as so why is dosimetry important? The first important dose for 190 it actually helps estimate the therapeutic benefit, and also it helps to determine the dose that may be safely sustained and anticipate possible adverse effect from the extrahepatic deposition of 190 microsphere. Because for 190 embolization, complication may occur such as the RE-ILD as well as pneumonitis. But still, for doing the 190 microsphere dosimetry, they come with some limitation. The first limitation will be the microsphere distribution is highly heterogeneous, not only for the tumor, but also for the not tumorous liver tissue. And secondly, the long beta particle range for the 190 microsphere also is neglected with current dosimetry methodology, and no reference on the dose volume effect for healthy liver and lung available in the literature for such a low dose rate irradiation. Before we can start the 190 embolization, the first step actually is to do a NaA mapping study, or what we call the NaA planning angiography. For this study, right, we actually using the NaA particle as a surrogate for the 190 microsphere due to the similar particle size. For NaA particle, the particle size is roughly 20 to 100 micrometer for the diameter. It's used to capture the end state of the in vivo diffusion of the particles. It can be either planar or SPECT-CT imaging. Is using the planar, you can help to get the liver to lung shunting percentage, and the SPECT-CT imaging actually can use to get the tumor to normal liver ratio. And also the NaH is used to capture any presence of the extrahepatic activity, such as those deposited into the gallbladder, pancreas, stomach, etc. After the NaA planning angiography, the angiography will be repeated after 1 to 2 weeks to facilitate the administration of the calculated 190 dose activity by infuse the 190 microsphere. And in the following slide, it should show you the different dosimetry method used for 190 dosimetry. Okay. By going down the list, actually, they will have greater precision and objectivity and lesser subjective estimation. Start from the empirical dose calculation, then followed by the body surface area method, then MERS method, and partition model. And on the foundation of partition model, it can be further refined into the super selective partition model, or what we call the vascular territory partition model. The empirical activity calculation is very simple. They have a recommended dose for different tumor involvement, like 2.5 gigabecquerel for liver involvement by tumor 25 to 50%. And this recommended dose have to be further reduced if they have a liver lung shunt factor more than 10%. It's very simple, but now I think every hospital, every center had abandoned this method because of the high incidence of RE-ILD, the radiation-induced liver disease. Then the second one will be the body surface area. The body surface area also is relatively simple because you just need to use the equation to calculate what is the 190 dose you want to deposit it into the patient. But it's lack of anatomy accuracy, and of course you cannot do a compartmental delivery as well. Still, the BSA actually procedure is the most prospectively studied model due to the information in several randomized clinical trials when the 190 treatment first started, and it can be the most common method for dosing the resin microsphere before the partition model appear. And the calculation is very simple. You just need to get the body surface of the patient minus 0.2, and then to find out what's the tumor involvement in the liver, and you will increase the dose accordingly. This is how we do the body surface area calculation last time. And the MERS methodology, unlike the radionuclide therapy I have mentioned just now, for 190, they have almost no physical decay. So for using the MERS, it will be relatively simple. It's roughly equal to per GBQ, per gigabecquerel, you will roughly get about 50 gray for the lesion. Still, you need to require the volume calculation of the target hepatic tissue, and it is assumed a uniform distribution of the activity inside the liver as well as the tumor. And partition model is the most accurate method of estimating the 190 dosimetry now by separate into 3 compartments: the tumor, normal liver, as well as the lung compartment. This is how the partition model works. And just now I mentioned about the vascular territory partition model. So in the new paradise, the administration of the 190 microsphere can be further refined into artery-specific multi-sub-partition model. So instead of the normal lung liver tumor compartment, we now have the lung multiple liver segment, multiple tumor compartment model, depending on the vascular territory mapped by the hepatic angiography. So here actually an example about how the vascular territory partition model look like. So instead of just consider the liver as a whole, they actually separate the liver into 3 compartments by different hepatic artery supply. So they actually separate into the right hepatic artery, the medial hepatic artery, and the left hepatic artery. The partition model is, of course, technically demanding and manpower intensive. It still has some limitation by the technician 99 and NaA as the microsphere surrogate, because they are, after all, it's not the same particle size. And also the distribution may be affected by the different position of the catheter when doing the angiography. But theoretically, it will be more accurate, and actually will be incorporate preference distribution of the 190 to tumor, liver, and lung. So here actually an example of a single tumor supplied by 3 vascular territory. And you can see the 190 microsphere actually can deliver into these 3 different sections. First by the right hepatic artery, followed by the medial hepatic artery, and the last one is the left hepatic artery. So after the NaA study have been done, we have to get the 190 activity we plan to inject the patient. So how can we do that? So first of all, we have to draw our eye on the CECT, the contrast enhanced CT, to get what's the volume of the liver, what's the volume for the tumor, as well as the lung. Then we can transfer this RI into our NaA image then to get the count from the NaA study. So here I actually show you two examples. The first one is a single vascular supply tumor, and the right hand side actually show you tumor supplied by two vascular artery. So after we have get the volume from the CT as well as the count from the NaA, we actually can plug those data into the partition model provided by the vendor of your hospital cell map spreadsheet. Okay, like on this slide, the left-hand side actually show you the partition model spreadsheet provided by Suspire. So you can actually insert the NaA count into this spreadsheet as well as the volume, and at the end he actually will have you to calculate what is the liver lung shunt factor as well as the tumor to normal liver fraction ratio. Okay, on the right hand side actually is the spreadsheet developed by Singapore General Hospital, my hospital. We actually using this spreadsheet to calculate our dose to the patient, and the activity of the 190 microsphere actually can be defined and decided by three different dose limit. The first one is the liver dose limit, followed by the lung dose limit, and the last one is try to achieve the maximum dose to the tumor. Okay. So here is a publication we have published on the 20 trial, which according to our research data, across all the patients, the predicted mean dose was more than 91 gray to the tumor and less than 51 gray to the non-tumoral liver and less than 60 gray to the lung. And we have achieved 100% tumor response with the predicted mean tumor radiation of subdose more than 91 gray to the target volume. And there was no significant toxicity to all our patients. However, this one is very depend on the patient selection. So let's say is your patient have previous liver function issue, they are more likely to develop the complication I have mentioned just now. So using the partition model, you have to try to maximize the activity to give the highest tumor dose while controlling as much of the liver and lung doses. So for our N, is we actually try to achieve more than 100 gray to the tumor dose, but without exceed the two convex. The first one will be the lung dose should not be more than 20 gray, and for the liver is unilobar, it should be less than 70 gray, and for bilobar it can be lower than 40 gray. So after the post-treatment, we have to do imaging to confirm the exact location of the 190 microsphere. So the most popular method will be the bench-strong SPAD, but it comes with some advantage, like using a wide energy window, so it will lower the energy, sorry, it will lower the image quality, as well as it's impossible to do quantification for the bench-strong SPAD imaging. And the second method will be using a pad to do the 190 imaging. You will have better resolution, as well as you can use it to do the true subdose calculation, because the 190 actually have a small fraction of positron. So here I actually show you the accuracy in the target imaging. You can see that for the CT is where the liver and the tumor, and the NaA actually show you the pre-treatment image we get from the NaA study, and then the last one is the bench-strong scan. And compare with the PET, you can see for the bench-strong we roughly can see where is the deposition of the 190 microsphere, but the PET CT actually can show very good images about where's the location of the 190 microsphere deposited. So this is the PET reconstruction method used in my center. We have a GE Discovery 690 PET CT. So this is the parameter we have used to do the reconstruction. We are using an onsen reconstruction method with 32 subset, one iteration, and per bit position we scan for 30 minutes. So is 190 PET useful? Yes, for the first one, for quantitatively, actually he can help to give you the accurate location of the Y90. So he can help you to show that the target actually is appropriate, and whether it have any technical inaccuracy, like you actually have any extrahepatic deposition, and also help you to predict the future tumor response. And for quantitatively, you can use it to do post-treatment dosimetry, and also he can show you the intratumoral distribution as well. So using the 190 to do PET imaging, they have some good point. The first one is better resolution than the benzocaine. And also the cone incident gamma photon can be used for attenuation, and also much higher pixels resolution. But also have some disadvantages as well. The first one is the positron fraction is very low for Y90. It's about 32 per million count. And also poor count rate will lead to poor signal to noise ratio. And also the scanning time is quite long. It's about 30 minutes per pit position. So for some of the patients, it may not suitable because they may not be able to sustain the 30 minutes of imaging. Beside the imaging and dosimetry, we also have to take precaution when we do the Y90 embolization, because incident may happen, like Y90 spill or contamination. So SOP must be prepared and should be easy to access by the staff. All staff involved in the treatment should be stay until survey for contamination before they can get out from the angiography room. And the entry of all other staff into the room is registered. Is a Y90 spill does happen, okay, and all the scheduled procedures should be stopped temporarily until decay saved by radiation safety officer. It may take a few days because of the half-life of Y90. All NN staff working with radionuclide should be trained before they can involve in the therapy, in order to have correct radiation spill response, as well as how to learn how to do management of contamination. So we always recommended to put a radioactive decon kit in the angiography or in the intervention room. The decon kit should include the basic items such as PPE, like isolation gown, glove, and shoe cover, followed by the cleaning stuff like the absorbent paper, soup solution, as well as the radiation waste bag and radiation hazard sign. A smaller decon kit can be found in the transport trolley, which used to transfer the Y90 microsphere from the radiochemistry lab to the intervention room. And also all the radioactive waste after the decontamination, it should be sent to a radiation waste disposal room. We also have prepared an action card for the Y90 liquid spill in the interventional radiology suite. It have a few states. The first one is the immediate state. Like what to do is the Y90 microsphere does spill in the intervention room. And also it have some state like how to transfer the patient out of the intervention room and how to manage the patient, and followed by how to do survey on the staff who actually involved in this procedure, and how to decom themselves after confirm the contamination, and also the post-procedure management method. So in summary, Y90 test is an effective treatment option for HCC and hepatic metastasis patients. Accurate prediction of target and non-target subdose is critical for treatment planning, because this affects the treatment outcome of the patient. N99 and clinician NaA actually can be used as a conservative planning estimate for the Y90 microsphere, and the Y90 PET is clinically useful for allowing more precise localization and how to identify of technical inaccuracy and predict a future response compared with the Y90 benchmark study. And all staff should involved should attend radiation safety training before the training. Before the treatment can be started in the institution or hospital. And by this, I would like to end my talk. Thank you.
Thank you so much, Yang-Sun, for the presentation. It's very clear explanation on the yttrium therapy. Yang-Sun, may I know how frequent is the yttrium therapy in your hospital?
Actually, we have patient almost every week, and we only have 2 days in a week allowed to do this procedure.
2 days a week.
Yeah, roughly. Yeah.
That is quite many.
Yeah, many actually.
Yeah. So you have a whole team that you have the nuclear medicine team and then the interventional radiology, is it?
Yes. So actually, we have whole team include the nuclear medicine as well as the intervention radiology to help us to do the angiography for the NaA as well as the 190 infusion.
So usually you use PET-CT or you just do a breast lung scan?
Last time we actually using benchmark, but now we actually moving forward to the PET-CT scan for the 190. However, sometimes, as mentioned just now, the scanning time for the patient is a bit long. So some of the patients are not suitable for the PET-CT imaging. So they're still doing the benchmark instead. Yeah.
I see. Okay, thank you very much.
So let me ask something.
Yes, Kitty, what please?
Yes, right. Because I think in most of the hospital in Thailand that use the yttrium 90, we use the SPECT CT for the post therapy scan. So we, as in SGH, so we have planned to go to the PET scan right now, and also our interventional radiologists they recommend to use the PET scan. So if we use like because right now we have the digital PET scan, so how do you think can we reduce the scan time for that?
Actually, it's also a difficult question. It's actually a very difficult task for us to do the PET scan for our patient, because the PET CT normally is occupied and have a very long list of patients per day. So what we try to do is we try to do the PET scan at the very early of the day, like the first K of the PET CT. So in this way, is help us to better manage the patient. Yeah, so we normally will scan it as the first patient. Is we do have to scan the 190 PET. Yeah. Because normally if we start the operation like about 9:30, so the FDG patient will start their first scan at 9:30. So before that, after we have done the daily QC for the patient, we actually will do the 190 first. Yeah.
Okay, thank you.
Yeah, thank you, Yang-Sun, and thank you, Kitty Watt. Yang-Sun, I'm not sure whether it's confidential questions. How is the cost like?
I have no idea because I'm not involved in the financial planning. Maybe Mr. Soma can help on this one.
I think it differs country to country. There's no subvention from the ministry, so the patient actually has to pay for the full amount. But I don't have the exact figures, but I certainly can find it out for you this week.
Thank you so much. Reason I asked also in Malaysia, the government is not subsidizing, so patient have to pay full amount. And I heard it was produced in Singapore. Yttrium was produced. Is it produced in Singapore?
Well, it's not that the yttrium 90 is not made here, but we put it together in Singapore. They bring the raw materials and they put it together. That's for the Asian market to make it cheaper, or maybe increase the profitability. I'm not so sure about that, but for the vendor, yeah.
Yeah. Okay. Thank you so much, Mr. Soma. I see Basam raised the hand. Basam,
Yes.
you want to ask any question? You can unmute yourself. Yes.
Yeah, thank you very much, Dr. Young. I have just questions regarding to dosimetry. You mentioned there are 4 models for dose calculation. I have just one question. What is the main difference between MERD formalism and partition model?
Oh, you mean
you mentioned, partition. You mentioned partition is the most accurate model for dose calculation. In terms of what it's accurate?
Okay. So the advantage for partition model is actually you can actually separate the liver into multiple segments. So instead of just consider the liver as a whole, then you just deliver to one position by insert the catheter. You can actually depend on your need. You can actually separate into like actually partition model. Actually, the normal one we use is the F1 version, like the one I have mentioned, the vascular territory partition model. So based on the blood supply, because the theory for Y90 is the tumor actually will absorb the Y90 due to the blood supply. So is the hepatic artery, you can actually find out what's the involvement of the tumor blood supply from different hepatic artery. You can actually decide for each segment of the liver, what is the activity of the microsphere you want to deposit. Let's say you find out the blood supply is mainly come from the right artery. You may decide for your 30 gigabeker of the Y90 microsphere, maybe 18 gigabeker of the Y90 you want to deposit it to the right artery, and then the middle and the left you can actually use the remaining amount. So the advantage for partition model is that it helps you to better calculate the Y90 activity into different region, and due to because of the heterogeneous distribution of the Y90 microsphere, you can better achieve the tumor subdose, like to achieve more than 120 gray for your tumor, and not violate the two limiting factor like your lung and your liver, those limit. I hope this answers your question.
Yeah, thank you very much.
Yeah, yeah, thank you so much, Yang Sun. Do we have other question? Let's see. No, we don't have any question at the moment. How much? Oh, sorry. Yeah, Christina asking how much maximum dose of yttrium?
Wow.
Yeah,
Okay.
the thing that I mentioned, because before I was calculate in my hospital about you know, like it can be up to 4 or 5 yeah, but I think
okay. I think I can try to answer this question. I don't have the real result with me now. I mean, we need to check with my doctor. For most of our patient, I remember we roughly inject roughly 30 millicurie, and maximum is roughly 60 millicurie or so. The well come to us like about 80 millicurie. So based on my memory, is it served me right? It's probably about 30 millicurie we give to the patient. Yeah. Yeah, but the maximum I probably have to check with the physician before I can really answer your question. Yeah.
Okay, thank you very much, Yang Sun. Don't see other questions here.
Okay,
Yeah, shall we move on to the next talk? Yeah, thank you very much. Yes, so last one, we have our last speaker here today is on personalized dosimetry in targeted radionuclide therapy by Nur Hidayati. Nur, I call her Kat Nur. She's involved in multiple IA CRP projects and also recently in the unskilled meeting as well. Nur, I will let you to talk about your project. Thank you.
Okay, thank you everyone for joining us today for the fifth webinar of AFOMP. I'm so excited because let me share my screen. I think, okay. Can you see my screen now?
Yes, we can see.
Okay, yeah, okay. Maybe good afternoon, good evening, or maybe good morning for everyone. Thank you. And this is my topic about the personalized dosimetry in targeted radionuclide therapy. As Chai Hong mentioned about me, she's my little sister. Okay, and my name is Ram Hidayati. Among us, maybe I'm the only one who doesn't work to the hospital, because I'm working in the research center for safety, meteorology, and nuclear quality technology. It is part of a research center for the National Research and Innovation Agency, but we have nuclear medicine technology laboratory. That's why we are doing in nuclear medicine technology and radiation safety as well. Okay, next. And this some outline of my presentation today. I will talk about how, why we need to do the personalization or personalized dosimetry, and there are some reports, some studies, and also the story from our experience in Indonesia. I will start with GSR part 3. I think all of you already know this, but this is some interesting paragraph in GSR part 3 that we should, we are medical physicists, we should ensure that each patient for radionuclide therapy before administered with radiopharmaceutical, we need to know how appropriate the activity that need to be administered. That's why this is so important paragraph for the basic why and how and the reason why we do the internal dosimetry for a patient in nuclear medicine therapy. And also, this is maybe some of you already knew, but I will talk at least why, the reason why this internal dosimetry or personalized dosimetry, it's getting high. The issue has been raised with this joint statement between IA and WHO. They would like to promote research that improve the method for organ assessment, including patient dosimetry when using unsealed radioactive source. That we already know that external beam radiotherapy already have a standardized or well-established internal dosimetry for the patient. And at the moment, this event has been supported by many international organizations, and one of it's us in International Organization for Medical Physics. And also, I assume that all of you knew this book. In this book, regarding the dosimetry internal has been stated clearly that the purpose of performing dosimetry for a patient in radiotherapy, it's to optimize. Why we need to optimize? Because this is something related to the radiation protection, and the purpose or the goal is to achieve the highest possible absorption to the tumor and with absorbed dose limiting toxicities. With regard to the how we establish those limiting toxicities, as we already discussed before, in nuclear medicine, we still have in debating issue. But let me show you some evidence that actually in in radionuclide there are, it's very specific dose, especially for the kidney in PRRT. Okay, and we should know that each patient, if we have data for each patient, of course, we do like individual. That's why in dosimetry, sometimes we heard about the term of individualized or is personalized. We will have a specific data for each patient. Then the goal again is going to the optimization. So with this, I think the goal is almost the same for external beam radiotherapy. But how we do that? Before we go to how we do that, there are some rationale of patient-specific dosimetry or personalized dosimetry, because how we perform the radionuclide therapy is, first it's like chemotherapy paradigm. When we administer administered amount of drug with the activity unit per mass of body weight, and the maximum activity if sometime defined during phase 1 trial. So it's been defined by the toxicity to the weakest patient. And with this paradigm, neglect interpatient with pharmacokinetic variability. Sometimes it will be undertreated, or sometimes it will be overtreated in a large fraction of patients. With the radiotherapy paradigm, the effect of how we administer the drug of the radiopharmaceutical or radioisotope, it's induced by ionizing radiation, but this we can monitor individually. In terms of the dose delivered, we use the energy absorbed per unit mass of tissue. So the absorbed dose is in gray. There are some publications that have interest issue. For the first one, it's come from Dr. Joe Soros, that it says that the objective of dosimetry in targeted radionuclide therapy is to provide information to, with the data, it will help improve the patient care. So we need to estimate the absorbed dose, so we can use the absorbed dose to predict or to estimate the extent that it's related to the response. Another thing that it's come from Lydia Strigari for European Journal Nuclear Medical Imaging. The evidence strongly implies that there is a correlation between the absorbed dose delivered and the response and the toxicity. And the last from journal, the Personalized Medicine, I will give some table and some explanation with this journal Personalized Medicine, that if we used one size fits all, it's approach that appears inadequate and does not guarantee either optimization or best standard of care of the patient. For example, that I mentioned before regarding the kidney dose, there is some evidence that in lutetium dotatate for PRRT, the kidney dose, it's never reached 10 gray. So when we talk about the NBD or the limiting dose for kidney, we can see this in this review publication published paper. So it has some evidence that about more than 700 patients treated by the lutetium dotatate, and the dose to kidney is rarely up to 10 gray. Okay, I mean more than 10 gray. And this is also for Yodium-131 and MIBG, and also for the PSMA. The absorbed dose range for the patient, they also only put on the parotid gland inhalation, and for the radium, in this publication, they talk about the red marrow as well. And maybe if you go to this publication, it will tell you more about the how that the personalized dosimetry in targeted radiation therapy or radionuclide therapy, it will give a variation of organ dose. Again, we see the merged formalism at the moment. We also already know that between in merged formalism that we have a source to target. So if we got some data for doing the dosimetry, so you need to have this graph like the activity versus time, and we need to calculate the dose by summing between the altitude or the cumulative activity in here in this part and times to the S value. The S value, sometimes we got this S value from Monte Carlo's calculation. However, if we want to improve the attitude, we also need to improve the S value. And in I also know you that about Olinda version 1 and version 2, they have the S value for some organ. And this is how we calculate the S patient from the Olinda that it's already the phantom. And if we have the mass for the patient, we can find the S patient by calculating from the S phantom and M phantom in the Olinda. And also the total body mass and for the phantom and the patient, you can get from the Olinda as well. And this is some publication from Anna Sunlov from European Journal of Nuclear Medicine and Molecular Imaging. They have a review for some method. Sometimes they have like 1, 2, 3, 4, 5 time planar imaging and one spec at 24 hours after the administration. Then it can be used for individualized dosimetry based treatment. And so there are some methods that as my colleagues mentioned before, at the moment, we don't have any standardized how to perform personalized dosimetry, but at least we trying in use one of the method in nuclear medicine at the moment. Then this one is come from European Journal of Nuclear Medicine, of course. Why most of publication regarding the personalized dosimetry or individualized dosimetries come from European, because they already have the group for dosimetry in targeted radionuclide therapy. And this is come from Marta Cremonesi that show the evidence of clinical benefit for implementation of dosimetry in PRRT. And they have suggested that the standardized methodology should be carried out into to provide the predictive paradigm to establish effective tailored PRRT. But still, it's also come from Lydia Strigari, but this paper is mostly reported about the significant Subdose effect relationship. In this review article, it says that dosimetry was found to be more predictive when the solid tumor or a localized organ like in kidney or liver were analyzed rather than hematological tumors. So it will be more predictive, it will be more effective if the tumor is in solid tumor in localized organ. I would like to start with some dosimetry tool from the basic. This is come from publication, of course, in 2005. But at the moment, I have chance to learn about the basic from how we can use a software for treatment planning that we can use with the 2D dosimetry with the planar imaging. And at the moment, this software only produce time integrated activity coefficient, then we do need another software like Olinda XM as a treatment planning. But there are some evidence also that this Subdose software is already being upgraded to be a Subdose software. And this is the Subdose software. Then in this upgrading tool for treatment planning in molecular radiotherapy, they realized that there are many kind of source of error during the 3D dosimetry. The first thing, the dose calibrator, of course, we have many issues with dose calibrator if it's related to the key A or key C of the instrument. And how we drawing the region of interest also can be a source of error. The image reconstruction and the correction, and also in inhomogeneous pharmacokinetics. When we deal with the pharmacokinetics, sometimes it's also have it can be a source of error as well. And the calibration factor, which is different one machine with another machine, and the counting statistic, and also with the fitting and the S value. So this is the source of error that we need to be careful when we performing dosimetry in radionuclide therapy. There is some, I'm go back to the ICRU report in term the Subdose specification in nuclear medicine, that what is the main requirement for our personal patient dosimetry in radionuclide therapy? First, we need to have anatomy information, mostly in CT or MRI images. Then we should have information about the radionuclide distribution in the body, so we can use the SPECT or PET images. And with these two data, we can register in each time point. Then we need to method for calculating the dose in target tissue from the source. Then we can get the S value. When we talk about the tools at the moment that we have, like commercial software, what are the feature that we have? For example, now we have the IDEC for model-based dosimetry, but with IDEC we need to have the cumulative activity in the organ. We can only input the cumulative activity. Also with Olinda version 1 and version 2, we can fitting the TX, but not for Olinda 2, but for the registration and segmentation for Planet Dose and Stratos and Kidos they have. And this, I don't know, with Hermes GA and maybe my colleagues from Thailand and Malaysia, maybe they already have it and maybe already work with the Hermes as well. However, in this publication by Mora Ramirez, they mention about the dosimetry tool should be have. The first, we need gamma camera, then we can do the reconstruction, the CT sampling, registration, segmentation, and when we get the TIAC or residence time, then we can go the Subdose. And for the information in this publication, the Planet Dose at the moment, it just says soon, but I have experience using the Planet Dose in my CRP project. So the Subdose, the Planet Dose can produce the Subdose to the organs. Oh, sorry. And this is what they have as the comparison between Panedose and Stratos and Hermes solution. Dosimetries, personalized dosimetry also can be used for retrospective study. If I can show you one of example that we have done with some few colleagues from Australian Institute, that at the moment they performing the retrospective study for the patient after 3 or 4 cycle with about 8 weeks apart, spanning in 6 months. So the SPEC CT scan, sometimes they have 3 time point between 4, 24 and 19 or 96 or 120 hours after the administration of lutein. Then in this publication, we found that the dose kidney is safe. This is the project from IAA. Then at the moment we work for IAA coordinated research project in molecular radiotherapy for personalized patient treatment. Then at the moment when we start in this project, we also have no idea which one of the dose limiting that we will use, because there are many information regarding the dose limiting organ for the kidney. This publication say that it should be 27 to 29 gray, and another publication say that it should be 23rd gray and refer from external radiotherapy. But with the project, we first time using lutetium-177 and in Indonesia for a clinical use. So the goal at the moment is establishing the Symmetry protocol in Indonesia, and this is the member of the CRP project. We have a friend from Colombia, Croatia, Cuba, France, India, and South Africa and USA. And at the moment, we use the data from South Africa with 5 time point with SPEC-CT. Unfortunately, I haven't, I mean, at the moment we are in the middle of publishing the result of dosimetry in this project, so I can talk you to give more information, but when the published paper already being published, I would like to share you how the result of the publication. However, before we start the project, we learned that to produce some good data, we need to make sure that our machine is give the good result with the precision, with the accuracy. So we start with the phantom study with the source of lutetium-177 with the phantom, and we start with a patient with lutetium PSMA, but in the end of project, we use the data for the lutetium detected for pre and post therapy. The challenge that we face at the moment, we want to perform the 3D dosimetry, but by the ethical committee, we can do the few time point with SPEC-CT, so the 3D dosimetry was not allowed. So at the moment, we have planned dose, but we can use for inputting the data for ourselves. So this is the result of the lutetium PSMA, and this is some region of interest that finally we use 2D dosimetry, like using in the few conjugate method and resulting the activity in the organ, and we put the activity into the Olinda. This is that interesting finding from a survey from Europe region that at the moment, at the first we think that maybe all European institutions have applied dosimetry, but this survey show us that they have more than 200 responders from 26 European countries. So not every institution have applied dosimetry because the problem was the problems were identified as that there are shortage of knowledge and know-how, and also the shortage of medical physicists working in nuclear medicine, and also limited access to scanner or other equipment needed. So, and this dedicated software, I think this problem also happen in my country as well. There are not many institutions have the dedicated software for performing dosimetry. And also the lack of legislative requirement to perform dosimetry. So my summary here, so why we do the personalized dosimetry is this. We need to perform radiation protection of patient as optimization. And it's not easy to perform the patient dosimetry, but it should not refrain us from doing what seems to be the most appropriate. And this is that I love the quotation. Anything worth doing is worth doing poorly, and it doesn't have to be perfect, just get it to work. So if your institution have not yet performed dosimetry, we just need to continue to learn, and maybe someday that you can do the dosimetry for your patient. Okay, thank you for your attention, and this is my email. Maybe if we have some question that I can not answer today, please send email to me. Thank you.
Thank you so much, Kak Nu, for your sharing, especially on the CRP projects. I think our audience here, they are mostly very young medical physicists working in the field. So it's good to show them like what are the projects available, especially this regional projects is very meaningful, right? And we get the support from the IAA.
Yeah. I believe that maybe from this community, we can start doing something related to symmetry in our region. It will be more interesting for us to share. I think the problem in every institution may be different, maybe the same. So how do we solve the challenge? That's the interesting, I think.
Yes, definitely. Yes. Okay, so we have come to the last session today. We apologize, it's very long sessions, but this is why we have this AFOMP symposium, because it's more targeting to like the young medical physicists in the career, and it's for sharing of knowledge. We might touch some, some basic, some advanced knowledge and all. Yeah, so now we come to Q&A sessions. If anyone have any questions or any comments, you can type it in the chat, or you can just turn on your mic and say something. Okay, I see questions.
Yes. Yeah, there are some free software at the moment. The free software and the IDEC version 2 is also now have a fitting function, but sometimes the problem is whether this is appropriate for clinical work or not. For example, the Olinda, it has like FDA approval for publishing. Yeah. But for learning, I think IDEC version 2 is also good. and I believe that you can sending the email for the author in the I can give you the website for IDEC version 2.
Yeah, the Christina has shared the open dose. It's one of the free one.
Yeah. So regarding the IDEC dose, so following Noah mentioned, the limit of the IDEC dose is only the adult model, the digital phantom, the pediatric and pregnant model.
Yeah.
But for the learning and for starting to calculate the internal dose, you can use the IDEC as Noah mentioned.
Can I invite Mr. Soma and Young-sun to turn on your camera as well?
Awesome.
Yeah, we can do a foreign style. Any questions for anyone? Yes, Melvin, are you going to say something?
Melvin was working even on a Saturday.
Wow.
Wow, very active.
Yeah, the link that I sent in the chat box is the open source. It's called Open Dose software. Just keep an eye. I just talked with the page the person who wrote this website. He said that he will run some freeware on the dosimetry calculation for therapeutic nuclear medicine. I think maybe in this year, based on Monte Carlo simulation.
Oh, there is some question as well. For how do we calculate the calibration dose? It's depend. If you use the 2D dosimetry for planar imaging, it will be easier. But for 3D dosimetry, you should have a phantom that a kind of JAG, but it has to, I can't remember the name of, you should give some different activities into the phantom. So we need to do spexity for the phantom, and then we calculate the calibration factor. That's the important thing. But for 2D dosimetry, you need to have the calibrating factor from the gamma camera. Maybe it's almost similar with the sensitivity parameter in the gamma camera key A or key C. And another thing that you need also like to know the attenuation factor for your machine. This for 2D, it's also simple. When you have slab phantom or water phantom, you can use the variation of the thickness and measure the source with the instrument, with your gamma camera. I hope I answer okay, especially for 3D dosimetry. I have some publication. Please send me email because I need to find the papers and I can send to you. It's Mr. or Miss Madhulika. Yes, I see the body phantom with fillable sphere. Yeah. I can't remember the name. Thank you, Krisana. Oh, Miss Madhulika. Yeah. Send me email with the so I can send you some papers related to the calibrating factor for. Okay, I send you email. Okay.
Yeah, that's very nice. Thank you. Yeah, I also have a summary PowerPoint slide. It's from the ICTP when I attended the dosimetry course there. So in the PowerPoint, it has a summary of commercial software as well as some free software, as well as some database that you can download and you can try it yourself. So if anyone interested, you can also email me. I can share with you the slides. It's provided by ICTP anyway.
Mm-hmm.
Yeah.
Thank you. I missed that workshop.
Yeah. Yes, any other questions or anyone comment? Yeah, maybe it's too exhaustive because very long session. Okay, anyway, let me just make a conclusion, a wrap up. So today we are talking about targeted radionuclide therapy. We just started. I have to say this field is still quite relatively young compared to radiotherapy and others, but we will get there when we work along. And the TPS system, I think very soon we will see the similar patterns in nuclear medicine. And dosimetry, a lot of people, they heard about dosimetry, they're scared because they feel like, oh, there's a lot of work and then you need to use very expensive software and all. But like what Gatnu said just now, we have to use the proper appropriate methods, right? If need to do, we need to do. So it's a development. So I think we can see the progress in the coming years. So don't be afraid. A lot of people thought I'm not good in software, I'm not good in programming, but that is not the point. I don't think that will be a limitation. Yeah. So other speakers, do you want to share anything? Maybe from our senior, Mr. Soma, any advice?
Not specifically on this matter, but the IEA is a good place to start. In the website, that is, there are many references as well as tech docs that are available as well, including in internal dosimetry as well. So I suppose that's, in fact, Noor had shown one of the slide on the textbook for nuclear med, and that's very excellent for young medical physicists who are coming on board and who are wanting to practice in nuclear medicine.
Yeah, thank you. Who is the next? I don't want to go by seniority. Kitiwa, anything you want to say?
Yes. So I would like to thank all participants to participate in this workshop. So it seems this is a very successful workshop regarding the nuclear medicine. Yeah, as I mentioned, so we are on the learning curve about the modern nuclear medicine right now, and also for the personalized nuclear medicine. So I think hopefully if we have the very strong community and very good connection between nuclear medicine staff, yes, I think we can go to nuclear medicine will be the forefront in the radiology fields in the future. I hope like that.
Yeah, we should work closely together. Thanks.
Yes.
Kanu, any final words?
Okay, thank you for inviting me, and I'm really expecting that the future project will be the first of dosimetry, something in our region. It will be interesting. Thank you.
Yeah, thank you very much. Dr. Krisanath?
Yes, thank you for organizing this AFOMP school. And as Nu says, this dosimetry in nuclear medicine is quite new. Even if in the European region, they still have a shortage of the medical physics for nuclear medicine and also for the knowledge of the dosimetry. So I think that the answer is the strong community of the nuclear medicine in Asia. Even if in your country, I think just ask the question. Don't afraid to ask the question, and we can share. In some question I might can't answer, but I think Dr. Kitiwat, Dr. Chai Hong, Dr. Soma happy to answer. Just build a community for learning and with the dosimetry. It's very new. Yeah.
Thank you very much. And Yang Sun?
Okay, I think, yeah, so actually my senior already said, already read up everything. There's still a new fields and we're always learning about how to make it become better. I hope next year when we have the lecture, we can just share more things with you all about what we find throughout the next year. Yeah.
Yeah, thank you very
Sorry,
much.
Chai Hong, can I say something
Sure.
else?
Please.
I just want to highlight that radionuclide therapy, you really, really need a medical physicist. There is no running away. Please highlight this to any of your nuclear medicine doctors, especially in the private sector in your country. If they intend to start it, you need to have a medical physicist and a trained medical physicist. And that's an important thing. Diagnosis, they can do it without one, perhaps. That's also risky, but for therapy, you must have radionuclide therapy. You need to have a medical physicist. And as shown by all our speakers as well, in terms of internal dosimetry, in terms of safety, in terms of contamination control, radiation safety, etc. Thank you. That's about all I have to say.
Yes, very good. Thank you so much, Mr. Soma. I think that make our conclusion today. Yeah, and I have to say a very lucky thing is our community here, you can see we are all like, we work very closely, we know each other, we are very friendly, our seniors are here to guide us, seniors also are very friendly. So I think it's a very good community to start with in the nuclear medicine in this region.
Yes, I agree with you, Chai Hong.
Thank you.
All
right.
Take
So,
a photograph together. I mean,
yeah, I think
Yeah.
we should. Can I invite everybody to please turn on your camera, if you can, just for memory.
Yeah.
Okay, I see a lot of questions asking about the recording. Yes, we will post the recording on the AFOMP website. You just go to afomp.org. All the recordings of the previous webinars will be there. So, and also we uploaded to YouTube as well. So you go to YouTube, you search for AFOMP channel, you will find our recordings there. So all our informations are shared and on the free of charge basis. And for those who haven't filled up the certificate, please fill up through the link, and we will send you the CPD certificate. Okay, are we ready? Okay, I'll start taking a picture now. 1, 2, 3. Hold on, I need another one. Okay, one more time. 1, 2, 3. Okay, thank you very much. So that concludes our workshops today. Before you leave, can I please just share this? Okay, it's from my president. Very important. We have our next webinar. As I said, webinar is a shorter duration. It's only 1 hour. It's on June 3rd. It's on the topic of nuclear and radiological emergencies, role of medical physicists. So I think the flyer already circulated out, so you can register. And this is our speaker, Dr. Murali, and our moderator, Dr. Mary John. So please register for the webinar if you are interested. And for the symposium, will be on the 3rd Saturday of the month. You can go to our AFOMP website and www.afomp.org. You click on the AFOMP school here. You can find all our upcoming school webinars, and all the recordings are available here. And they're also available on YouTube. So just search for AFOMP channels. You can view back all the recorded lectures here. Yeah, thank you very much, everyone. And thank you so much for your time to join this symposium on a Saturday afternoon. Yeah, I hope you find this useful, and we'll continue to do our best. Okay,
Bye.
thank you, everyone. Bye-bye.
Bye, everybody.
Good weekend.
Thank you so much to all the speakers.
Bye,
Okay,
no.
thank you.
Bye.
Bye.
All the
speakers.
Bye, Soma. Yeah.
Thank you. Bye.
Chai Hong, bye.
Thank you.
Bye. Jai Hong, I will looking forward to see you in Malang.
Oh, I'm not sure I can go or not.
Tell me later.
Okay, I'll tell you later.
Okay, bye-bye.
How do I go there? How can I fly there?
Let me call you later.
Okay, all right.
Okay.
Okay,
Thank you.
so much,
Thank you,
everybody.
Bye.
Bye-bye.
Bye-bye.